Good morning, good afternoon, good evening. We have a global audience today, depending on where you are and where you're going to be tuning in from. We'll give another minute or two before we get started.
While we are waiting, whoever has joined in, why don't you put in the comments where you come in and or joining from? Let's see if we get any.
Let's take this virtual stage. Hello, everyone from here, chilly upstate New York. Thank you for joining us to those who know us already from our podcast and in-person discussions. And welcome to anyone who's getting to know us today for the first time. I'm Rahul Gosain, here as always with my brother and your co-host, Rohit Gosain, and we are the Oncology Brothers. We're live broadcasting our first ever social media discussion, and thanks to Medscape Global Oncology for this opportunity. Anyone who's joining us can appreciate that the amount of data that's coming at us in the world of cancer is truly overwhelming. And honestly, it's daunting to keep up with all this research. Our hope with our platform and these ongoing bite-sized discussion, like today, is that we really hope that you stay up to date so that we can provide that best care for all our patients close to home. So over the next 25 to 30 minutes, today we're focusing on treatment options in refractory metastatic colorectal cancer. And for this, we're excited to welcome Dr. Nina Vijayavargiya from Fox Chase Cancer Center and Dr. Tiago Biaki from Moffitt Cancer Center. Nina and Tiago, thanks for joining us.
Absolutely, great pleasure.
Thank you so much for having us. I'm very excited to be on a live event and talk about all things colon cancer.
Indeed. Welcome, Nina and Tiago. Before we talk about refractory disease, which is the point of topic today, it is important to acknowledge that early onset colorectal cancer is on the rise, and guidelines rather now recommend screening colonoscopy at the age of 45. So now, with regards to where do we stand from our treatment paradigm, if one is diagnosed at an early stage, treatment is rather surgery and then followed by adjuvant chemo, which is 5-FU-based or capecitabine-based. For stage 4 disease, our treatment options stand. If one has MSI-high disease, then immunotherapy is the option. If no targeted mutation, then one has to utilize 5-FU-based chemo with bevacizumab or anti-EGFR, or with encorafenib and cetuximab in cases of BRAF V600E mutation. If disease has now rather progressed, relying on 5-FU irinotecan, that is, if it has not been utilized before, and not forgetting our bucket approval, especially for HER2. And then what? That's exactly what we are here to address. In that case, our treatment options stand are TAS-102 with bevacizumab, regorafenib, and fruquintinib. At this juncture, patients have seen quite a bit of chemotherapy. Despite the side effects, they are willing to try other therapies because all these 3 therapies have rather done well when compared to supportive care. Nina, starting off with you here, focusing on regorafenib. This was rather first approved about a decade ago. So what data do we have around this drug? How to rather dose, especially when we talk about the redose study, and where are you using this in your treatment paradigm, especially when you have 3 of these options approved in refractory settings?
Absolutely. So yeah, I was actually a fellow when regorafenib was approved more than 10 years ago. And we were actually part of that study at the time. So I have vivid memories of the drug. We also did IST with it. But basically, I think regorafenib is a VEGF TKI, which is called a dirty kinase because it hits a lot of other things apart from just VEGF 1, 2, 3, and many other oncogenic tyrosine kinases. The data that we have for regorafenib is from the CORRECT study, big study, 700 patients, and they used regorafenib at the dose of 160 milligram versus placebo. The overall benefit in OS was modest, 1.4-month improvement in overall survival from 5 to 6.4 months. The PFS was only like 2 weeks, 1.7 to 1.9 months. Nonetheless, it was statistically significant and the drug got approved. But while using the drug, we all found there was like a lot of significant toxicities, right? Grade 3 or 4 hand-foot syndrome, like that was a real deal. It's like even up to 17% was seen with that study. And over time, there was liver dysfunction. I always thought that it took the will to live away from somebody just because it makes you very fatigued and tired. And then we like decreased our use, and then came the redose trial. In redose trial, what they ended up doing was they started at a lower dose, right? So instead of the 160, you start at 80, and then you build to 120 a week later, and then you go up to 160, matching your high blood pressure and your hepatic function tests, etc. And that increased the tolerability a little bit, but nonetheless didn't affect its efficacy as much. And as a result, I think over the years, it has fallen to the point of where we don't have other options. That's when we use the drug. And as you just mentioned, colorectal cancer patients do maintain a performance status to try new agents. They're in fact the most commonly enrolled patients on phase 1 studies. And that's why, we have option. If we have an option, if you have a study, you go on that. But if not, it is still used every now and then.
Thank you for going over that historic data. Rohit, can I go back to where you started? I think it's important to reiterate that upfront comprehensive NGS at the initial time of diagnosis is very important, right? You touched briefly on Breakwater for BRAF V600E, which showed doubling of overall survival. And not just BRAF, it's important for us to know RAS, HER2 status, and sidedness can also play a role in that upfront settings. Okay, coming back to refractory disease, Nina, as you stated, initially when we were using it at the time of approval, the regorafenib dose was higher, but based off redose study, now step-up dosing, if you're going to use regorafenib, is the standard of care. But we still have to keep things like diarrhea, hypertension, and fatigue in mind because our treatment here is with palliative intent. Tiago, when it comes to sequencing these available options, we're relying on real-world data. And in this space, we also have TAS-102 with bevacizumab based off Sunlight trial and fruquintinib based off Fresco study. In your practice today, how do you sequence these available TKIs versus TAS-102?
I knew that this question was coming. So I was reviewing, dates, a couple of days ago for our discussion today. And then I realized that, wow, it's been like 10 years that TAS-102 was approved, as monotherapy. So time is flying so fast. So yeah, I think that the bevacizumab gave us a little bit more optimism with the TAS, because the improvement was a little bit more significant, like 3 months versus like 1.5 that we saw with regorafenib, etc. I think most of this, decision, of course, we don't have like head-to-head comparison, and we're not gonna have this because if we have any difference, we will need 100,000 patients for this kind of a trial. But I think it's mainly based on toxicity profile. And when I say toxicity, we have this idea as investigators. We all focus on grade 3 and higher toxicities, etc. But for the patient perspective, I feel like we have to think about sometimes lower grade toxicities as well.
Absolutely.
So it's not easy, and I have this conversation with other investigators sometimes in meetings, etc. It's not easy to live with a grade 1 or 2 diarrhea for 6 months. You might be preventing this patient having a social life with that. So I think the type of toxicity is important. As you said, these patients they have been on chemotherapy for 1-2 years, and sometimes myelotoxicity is already an issue for this patient. He's having growth factors combined with the chemo. So maybe for this patient, TAS-102, which is a drug that can cause more myelotoxicity, is not the best idea. Or sometimes this patient is not willing to travel to get the bevacizumab, etc. So for that patient, maybe fruquintinib might be a better option. On the other hand, I do have patients, and this is because our geography here in Florida, even if this patient is coming from the other side of the state, it's still like a 2.5 hour trip. So sometimes they prefer to come here every other week, for example, to have the bevacizumab, and that's fine for them. And in those patients, probably prefer TAS-102 with Bev because actually mainly because the data, the response rate is a little bit higher, 6% versus 1 or 2%, and because of this benefit, and overall survival was a little bit more significant compared to 1.5. But yeah, and we're far from the ideal scenario for this. Unfortunately, I think it's very frustrating when we see those curves falling together for 40% of those patients with the PFS. So we're just adding toxicity probably for about 40% of our patients. So we definitely need, better, biomarkers. Response rate is a big deal, at this point, because it's low for, all options that we have available. And I feel like this also needs like some patient education too, because for 2 years you've been, doing chemotherapy and, assessing the CTs and showing, hey, this tumor is shrinking here, your liver lesion is shrinking, etc. And then overnight you're going to start with a medication that can cause toxicity, and you're not going to see this tumor shrinking anymore. So patients need to understand that, we want to, prolong this life with quality. We want to try to minimize these toxicities, and I'm glad that we have more and more options. We're going to talk today about another option coming, but I think this, needs a lot of education for both parts, I would say.
Thanks for summarizing that, Tiago. It is important to stress that patient-shared decision-making is the key, especially when you're tying in these agents from palliative intent. Grade 1, grade 2 for a long period of time can certainly be cumbersome. Just to remind the audience that fruquintinib here in USA is available after exhausting 5-FU options, that is FOLFOX or FOLFIRI, while in Europe, it is actually approved after patients have had intolerance to TAS-102 or regorafenib. I know we briefly touched on the regorafenib side effect profile. Nina, with regards to TAS-102, the approval stands day 1 to 5 or day 8 to 12 for every 28 days. But of course, we have some data to utilize this every other week, and that's where this sort of better tolerated. From your standpoint, side effect profile and what is your dose regimen looks like?
Yeah, so I think, as was mentioned by Dr. Biaki, it is not easy to tolerate some of these drugs because of ongoing, continuous side effects. These are oral agents, and ongoing toxicity. It's like, that pebble in your shoe and you just cannot walk with it for too long. That's exactly what these things do to you. And it is very difficult. The TAS-102 in the original study was given day 1 to 5, 8 to 12. And the problems with that regimen was slightly, significant diarrhea and also cytopenias, which actually were like persistent on 2 weeks off as well. Compared to that, this new alternate regimen of doing it day 1 to 5 and then 15 to 19, because you're giving bevacizumab every 2 weeks, which makes it, you're being able to see them every 2 weeks, etc., is actually gaining popularity, at least here in US. There was this retrospective data that was recently presented, and, real world evidence regarding it too, which suggested that the PFS was preserved and the toxicities were lower if you do it this way, like day 1 to 5 and day 15 to 19. Yes, it is real world data, and there's a lot of, problems associated with it, but that's the best we have. We are working in the real world and we need to use it. So I personally tend to use it on day 1 to 5 and 15 to 19. The only time I actually don't use it that way is if I have patients that actually need growth factor. They've needed growth factors multiple times before, because when I do the first 2 weeks, I can actually use growth factors like, long pegylated G-CSF, but I cannot do it when I do day 1 to 5. So that's where I use it. But for the most part, it's every other week.
Nina, I must say your analogies, pebble in the shoe, and even for ctDNA, the horoscope story.
I like them. They keep me going.
But that's important, right? Coming back to the story of grade 1, grade 2, Rohit, you touched on this, saying they are cumbersome. Yes, and Jill Feldman, a patient advocate from lung cancer, often brings this up. If you're living with this disease with palliative intent, your quality of life is at the center of all this. So we have to be very mindful of this. Coming back to TAS-102 and Sunlight study, a fair criticism that comes along is not everyone in this study saw bevacizumab upfront. We were looking at this number, roughly about 30% did not, which is unusual in the US, right? Majority of our patients are exposed to bevacizumab upfront. That said, TAS-102 bevacizumab is how I tend to use in my practice and every other day as well, based off Dr. Kathy Ng's presentation on this retrospective study. Okay, while we're still talking about side effect profile and management, Tiago, what about fruquintinib? We touched briefly on the redose study for regorafenib for that step-up dosing. Can we extrapolate the same thing, or do we need to extrapolate the same thing for fruquintinib, or do you often just start at the recommended dose of 5 milligrams and then down titrate, or the other way around? What's your practice like around this?
Yeah, that's a good point. And I think that, the main difference with fruquintinib, is the dose for the pill. So it comes like with 1 milligram or, 5. And personally, I tend to start with the standard dose for fruquintinib, and I feel like, I don't know if Nina agrees with me, but I feel like it's a little bit better tolerated, compared to regorafenib. So usually it's easier, to give, fruquintinib. So I tend to start with the standard dose, but I follow those patients really close, at least, for this first month. So I might see this patient, next, and now we have this like Zoom, visits. This helps a lot. So this patient can get labs, locally. We can, do a Zoom like, in 1-2 weeks, and then we're going to start seeing this patient. If everything is doing well, we're going to start seeing this patient once a month. But I tend to start with, the standard dose. Sometimes we have some, we struggle with dose reductions because, if I have to dose reduce, I have to do 4, for example. I have to send probably another request for insurance, and then this patient might face some, delays, with the dose. So I tend to start with 5, and usually, it is okay if we follow those patients, close.
Okay, so now we have
That's our practice too. Sorry.
Oh, no. And again, the dosing here, the pills that we tend to use for fruquintinib is also tough to start off lower and then down titrate. So we have to be mindful about that. So we have some data here. We've touched on response rate. We've talked about side effects, but the practical aspect of this. Tiago, putting this all together, you have these 3 options. The disease is refractory. How are you sequencing these options? And Nina, I would love to hear from you thereafter.
I would add like a 4th option, which is rechallenge too for anti-EGFR. So this is important. So we have like more and more data now because, sinus, that we might prefer to use anti-EGFR, not for everybody, to be honest, but for maybe some patients with high volume disease, those patients that you need response. So if you used anti-EGFR in the frontline setting, you're gonna use like another chemotherapy, backbone in the second line. But if this patient is again back to RAS wild type, for the third line, you do have like some data from Italian group saying that, if you rechallenge this anti-EGFR, you might have like almost 20% response rate with that. So it might be an option if the patient did not experience, a lot of, rash, etc. If that is not the case, and I would say the second option, or the first option actually at this point, will be, of course, clinical trial if we have, anything available. And we have like more trials like with KRAS inhibitors, etc. But I tend to, start with, TAS-102 and BAV if everything is like okay with that patient. We don't have any contraindication to BAV, etc. If this patient, of course, doesn't have a lot of, residual myelotoxicity. Sometimes I've seen a couple of patients that, they were treated with too much oxaliplatin, and they develop like portal hypertension because of that. It's really hard sometimes to treat those patients with something like myelotoxic. But to be honest, the conversation that I have with these patients, like, okay, so this drug, this is chemo, this is different than TKIs, this is chemo, so you might have some fatigue. So that's why I also prefer this every other week approach. And myelotoxicity, wow, okay, that's a big deal, but usually this patient doesn't feel that, right? So I tell them, well, this is a number, we're going to follow this. Of course, this is important for you, but you're not going to feel this number coming down. But fatigue is the big deal. So usually, TAS-102 is my next option, and then fruquintinib after that.
And Nina, your take on sequencing?
Great, that's exactly what I do, right? I think, if I can give TAS-BEV to somebody, that would be my preference first, and then move to a TKI afterwards, after it. Just better tolerated. I feel definitely better tolerated than the other one.
Right, and just tying in some of the comments that we are getting on the comment section is that one has to tie in the response rate and patient-shared decision-making with the side effect profile. So we definitely want to reiterate that important point. And Tiago, what you mentioned about fruquintinib, with regards to the side effect profile, slightly more favorable when compared to regorafenib, because again, this oral VEGF TKI is rather selective, while what we are dealing with is regorafenib, which is, as Nina mentioned, a dirty TKI, which is rather pan activity there. With regards to something that we also saw on recent ESMO meeting in refractory setting was Stellar 303 trial with atezolizumab with zenzalutinib in MSS population, which showed overall survival benefit, but that was only roughly about 1.5 months. So rather 6 weeks when compared to 9.4 months in regorafenib arm versus 10.9 months with this new combination. But not to forget, this is coming at a huge cost of 60% of these patients had side effects which were grade 3 or more. for this marginal benefit, this high toxicity, well, we'll have to see if it really changes our treatment paradigm. But as of now, these three agents are still the go-to option. Tiago and Nina, with regards to sidedness, does that play any role in deciding your treatment sequencing or regimen at all?
I'd say for frontline for sure. So we have data,
in refractory settings.
Refractory setting, I would probably be, I would say, less excited, with rechallenge in a patient with the tumor on the right side. But for patients, because the biology disease, it's not because of the site, of course, it's because the biology of disease. But for patients with left-sided, if this patient's back to RAS wild type, I'll probably prefer to rechallenge before we jump to those three options. Regarding this Taylor, of course, I mean, we have to discuss this. It's it just came out. I don't think that this is something that we're gonna use for everybody. I think this is going to be like another option that we have, and a new kid on the block for this. And as you said, I mean, some significant toxicity, high-grade toxicities, but also like more than half of those patients with diarrhea, for example. Again, the same thing, like even like grade 1 or 2 diarrhea. And if we put in the context, this is of course not the first trial testing IOs, and we had like regorafenib with Nivo, regorafenib with Nivo and EP, Pembro with lenvatinib. All those trials failed, and now we have another one with IO that we know that it's probably not the most efficient one, and then we saw this benefit of 1.5. So again, I mean, it's really hard to say that this benefit is coming from the IO. It might be just because Zenza is a little bit better tolerated compared to those other TKIs. But it's interesting that for the control arm of this trial, they did not use the redose approach. So those patients started with the full dose, so which is it's I would say really tough.
And I think we have to remember the control arm here is regorafenib, and we were just talking how many of us use, like, if someone's progressed on fruquintinib, I rarely do regorafenib after that, like that's and here, like, so if I'm using fruquintinib first, I don't even use regorafenib, so that is always something to be kept in mind. And I wish that maybe the hand-foot syndrome was lower, right, as we had read on the study, which suggests that, because I think zenzalitinib is a shorter its half-life is shorter than our other TKIs that we have, so you can actually like back down if you have a little bit of symptoms and then quickly go back on the drug, so you may be able to get the drug in a more consistent way, leading to the small benefit that we see there. But we're waiting, maybe the non-liver met population data is going to pan out at some point, so we will see if that happens, but until then we're just on hold.
It's becoming harder to design trials in this scenario, because the field is changing. Every year we have like a new drug. So if I have to design a trial for third line now, which one I'm going to use as like control arm? So we might need to use like physician choice, and this is going to be like a very heterogeneous population, so it's becoming harder.
Yeah, it's a good thing, right? We have more things.
It's a good thing,
It's a good problem to have, because again, with these advances, our patients are indeed living longer. But just to quickly recap Stellar 303, the control arm was regorafenib. We did not use that redose step-up dosing, which is now the standard of care. But despite that, the therapeutic arm here with Zenza and Atizo had more than 60% of grade 3 toxicities and roughly about 37 in regorafenib, and that marginal benefit of 1.5 months. I do think that we have to do better with the toxicity. This by no means is a home run, so we're eagerly waiting to see how we can do. Nina, you touched on this. Majority of the benefit historically we've seen with immunotherapy is in patients with non-liver mets. And here, that is where some of that benefit was driving from. We certainly need more and mature data and get better at managing these toxicities before this becomes day in, day out standard of care. Nina, can I come back to you? Okay.
I think only if we see that benefit we'll actually somehow feel that the Atezo is adding something to the group,
Absolutely.
Right? That's what we really need.
Yep. Is this single agent good enough? Or are we just adding Atizo or immunotherapy for added side effects? Coming back to
again,
refractory,
unfortunately, we had the same type of curves like for PFS that we saw like in other studies, like they're falling together like till 60%. So we're just adding toxicity for about 40-50% of those patients, unfortunately.
Yep. Absolutely. And a lot of times we're sitting in our clinic talking about immunotherapy, that it's a non-chemotherapy option. but the side effects are not benign by any means. You can have life-threatening side effects from immunotherapy. So again, when we're adding these medications together, we really are looking for synergy rather than just added benefit. So we'll wait to see how single-arm TKIs continue to do. Nina, in refractory settings, does the side matter when you are considering re-challenging right versus left? Do we have any data on saying rego for fruquintinib or TAS-102 does better, or we just don't rely on that in refractory settings?
Yeah, in refractory setting, there is no data to suggest that sidedness matters. And I think the reason for that is, sidedness is just a proxy for tumor biology, right? We just think it's in. By the time you're in the third line setting, most of these therapies we talk about are not targeting any specific genomic or a phenotype, I would say.
Yeah.
But what we know is, just as we mentioned, the re-challenge with EGFR, I would not re-challenge somebody who progressed on an anti-EGFR in 3 months, right? So left or right-sided. But I would re-challenge someone who had a good response and stability for a long time. So there, the biology already dictated that I can reuse the drug no matter what side it is. So I think by third line setting, unless we start seeing more therapies, biology matters because, right, we are talking about liver and non-liver mets. So at that stage, that is what matters rather than anything else. Again, it's not that the liver mets prevent response to immunotherapy. It's just the biology is different, and that actually helps us define things. But I don't care about sidedness once I get to that point.
All right, before we close, we'll go around this virtual roundtable. Nina, starting off with you. Any final thoughts or anything exciting you're looking forward to in this field?
Yeah, I think lots of excitement, right? We have, if we were just talking about, we have 3 options to choose from right now. Maybe a 4th one will be added. We don't know. So that's amazing compared to a long time ago when, literally I remember when we opened the expanded access program for regorafenib, we enrolled 36 patients in 2 months, and only because there was nothing available.
Right.
Now we have options. So that's amazing. But for future, I would probably say there is so many different, target therapies. There's antibody drug conjugates. There's data in using EpCAM, MET. There is immunotherapy, and I'm not going to take the thunder away from Dr. Biaki and talk about that, but that is those are so many things that are coming down the pike that hopefully will help our patients more every single day. And there's it's re-challenge with chemo and adding immunotherapy to it. There's just very much, I'm very optimistic for the future for our patients.
Perfect. Tiago, final thoughts from your end and things to look out for, sir.
I agree. I think that, the future is bright here. Many things I would say, like bispecifics are, also coming with, too many options. Usually there are many, drugs out there combining VEGF with, mechanism of resistance, like VEGF plus TGF beta, or even VEGF with PD-1s, etc. So many of those companies actually trying to bring this to upfront, now combined to chemotherapy. So this is something really exciting. KRAS inhibitors, we know that this works even better for pancreas. It's a home run for pancreas, actually. So probably this is getting approved for second line, and they're starting trials trying to actually beat FOLFIRINOX in front line setting with KRAS inhibitors. It's not that easy for colon, so I have to say that we have a couple of trials here, and we have to combine with anti-EGFRs, and responses are not so great as for pancreas. In immunotherapy, this the presence of liver mets, it seems that this matters for immunotherapy. The phase 2 data with botensilimab and balstilimab was pretty exciting. It is toxic, so usually, if the patient doesn't have any, IO or severe IO toxicity, this is usually better tolerated than TKIs and, chemo, etc. But sometimes this can cause pretty, severe colitis, and those patients will struggle with that. But response rate was almost 20%, so it's pretty, exciting. And we don't know if this is, it's probably because the botensilimab components, it's slightly different compared to ipilimumab. But again, this, liver, the presence of liver metastasis matter. And I think, we have too many things, and we need more options that actually work for the liver, right? Because most of those patients, right, to remember, most of those patients actually they pass, unfortunately, because of liver lesions.
Absolutely. We've covered a lot here and reiterated the current standard of care and data to support our practice in this refractory settings for regorafenib, TAS-102, and fruquintinib. Let's not forget clinical trials, as that is what's advancing the field. And I know sequencing can be challenging, but it is critical for us to keep that in mind to make sure all our patients are getting exposed to these therapies so that they can live longer and better. Nina and Tiago, thank you so much for walking us through all this data and clinical pearls. For those tuning in, thank you so much for your time, your attention. We hope you'll join us back for these ongoing discussions around treatment algorithms, conference highlights, and new FDA approvals. With the Oncology Brothers here with Medscape Global.
Thank you.
Thanks so much, guys.